Okay, guys. This is the last installment in the chapter on the digestive system. So this is the back end of chapter 23. And we're going to talk about the rest of the accessory organs of digestion, and we're going to describe the chemical and mechanical processes of digestion that primarily concern the small intestine, the large intestine, the rectum, and the anus. So we're going to start off talking about the pancreas. Now, it is retroperitoneal and it's deep to the greater curvature of the stomach. It lies right underneath the diaphragm and behind the peritoneal membrane. On its uh, lateral aspect, on its left side, you're going to find the spleen, and on the head of the pancreas, you're going to find the duodenum, which curls around the head. And then the stomach is going to be right in front of it, so that gives you an idea about where this organ is located. So the head is encircled by the duodenum, the tail abuts the spleen. And as we talked about earlier in this chapter and earlier in the term, the pancreas is actually a dual organ because it can serve both an endocrine and exocrine function. Its endocrine function is to secrete insulin and glucagon to control sugar balance in the blood. Glucagon, remember, raises blood sugar while insulin causes blood sugar levels to drop. And of course, these hormones are vital in controlling metabolism. Its exocrine function, however, is to secrete pancreatic juice, and the cells that do that are called acini, and they're histologically distinct from the islet cells that secrete the insulin and glucagon. These components are relayed to the duodenum through the main pancreatic duct, and the zymogen granules of the acini contain proenzymes, which are essentially inactive forms of these powerful digestive enzymes. The theory behind this, well, the purpose of this is so that the enzymes don't activate prematurely inside the pancreas. If they did, they would actually digest the organ. And in fact, that is sometimes a cause of pancreatitis, an inflammation of the pancreas. So these cells secrete their components via vesicles into the pancreatic duct, and that's what carries it ultimately to the duodenum. Along the way, it's going to fuse with the bile duct that comes from the gallbladder. Now, remember that that's kind of the working definition of the difference between an endocrine and an exocrine organ. An endocrine organ secretes its products directly into the bloodstream through active transport, while an exocrine organ has to secrete its products into a duct, which is basically the biological equivalent of a hose, and from there either into the lumen of another organ or onto the surface of a particular tissue. Okay, so this gland meets the criteria for both. And this is just a look at the histology that makes up the acinar cells, the exocrine cells of the pancreas. You can see the duct here. Okay, this is the lumen of the duct lined by duct cells. This is an epithelial lining. And then you can see these acinar cells. And what you'll notice with the acinar cells is that they have lots and lots of zymogen granules and an extensive amount of rough endoplasmic reticulum, as well as mitochondria. And that's to be expected because remember that the rough endoplasmic reticulum is part of the protein assembly and distribution apparatus inside cells. So you would expect a cell that produces a lot of secreted proteins to have an extensive ER and to have a lot of granules. The zymogens, the inactive proteases, the inactive enzymes, are inside these granules. And what happens is that when these cells degranulate, when they extrude their products into the duct here, they then are moved along until they ultimately make it to the duodenum, where other enzymes, brush border enzymes, are there to activate them. And here you can see an actual histological section showing you the acinar cells and the pancreatic ducts. Notice that the pancreatic ducts are lined by simple cuboidal epithelia, and the acinar cells are distinctly different. They're sort of wedge-shaped, and These are, again, secretory epithelia, what we used to call glandular epithelia. Okay, let's talk about pancreatic juice. You make about over around 1.5 liters a day. It is an alkaline solution and it neutralizes chyme, and that's very important. Remember that the stomach, as a component of its gastric juice, contains a lot of hydrochloric acid, which is a corrosive liquid. And if we did not neutralize the hydrochloric acid coming from the stomach, we could erode the duodenum and produce either inflammation, or we could produce an ulcer, which could potentially become perforated, which would be a disaster, because then your GI contents would leak out into your abdominal pelvic cavity, and that is absolutely something we don't want to happen. The electrolytes that we find in this juice, primarily bicarbonate. The enzymes are amylases, which digest starch, lipases, which digest fat, nucleases, which digest RNA and DNA, and these are all secreted in an active form, but they require ions and bile for optimal activity. It's okay for these particular components to be active prematurely because once they're in the pancreatic duct, they don't present a hazard to the pancreas tissue proper. But the proteases have to be secreted in an inactive form because protein is a major component of cell membranes. It's a major component of connective tissue. It's throughout the organ. And if these proteases were active inside the duct, or active, even worse, inside the cells that produce them, they would destroy those cells. Protease activation requires the action of brush border enzymes that are actually in the lining of the duodenum. Okay, so these are called enteropeptidases, and what they do is that they cleave particular covalent bonds in these inactive proenzymes, these enzyme precursors, and when that happens, they go from being inactive to being active. Procarboxypeptidase, for instance, and chymotrypsinogen are activated by activated trypsin. Trypsin is activated by these enteropeptidases that are in the brush border, so it's sort of a domino effect once we hit the lumen of the duodenum in terms of activating now these enzymes so they can do their job. Now, what you're looking at here is just a diagram showing you the relationship between the stomach, the pancreas, and the duodenum. And what we're looking at here are the inactive forms of the proteases that come out of the pancreas. We've got trypsinogen, chymotrypsinogen, and procarboxypeptidase, and these are all the inactive forms of the enzyme. The trypsinogen is activated by these brush border enzymes. Then the active trypsin activates the chymotrypsinogen, forming chymotrypsin, and in turn the trypsin also activates the procarboxypeptidase, forming now carboxypeptidase. So again, a chain reaction. Now once these enzymes are all active, what they can do is they can continue the chemical breakdown of protein. And the way this works is that each of these enzymes, trypsin, chymotrypsin, carboxypeptidase, and pepsin, remember, from the stomach, all recognize a different amino acid sequence in the protein, and as a result their combined action produces what we call polypeptides, very short stretches of amino acids that will eventually be broken down into single amino acids by enzymes like carboxypeptidase in a amino acid by amino acid degradation that occurs from, again, the one end of the peptide to the other. Okay, once they're short enough, the carboxypeptidase can then act on them. But we have to get the proteins down to small enough polymer in order for these enzymes to be effective. Okay, bile secretion. Remember, bile is the detergent that helps us emulsify the fat that comes in with the chyme of the stomach. The reason, again, for that is to give the pancreatic lipase a little extra surface area to work on in order to degrade the fats into fatty acids and glycerol. Bile secretion is stimulated by bile salts in the enterohepatic circulation. That's basically in the liver circulation, okay, enterohepatic, and secretin from the intestinal cells, which have been exposed to hydrochloric acid and fatty chyme. Okay, so that's basically a stimulus. Now, the hepatopancreatic sphincter is essentially the door that opens and allows whatever's in the hepatopancreatic ampulla to enter the duodenum, again under the force of contraction of the squeezing of the gallbladder and the mass action that sweeps now the pancreatic juice in with the bile salts and ultimately into the duodenum of the small intestine. So it remains closed unless digestion is active. The bile stored in the gallbladder is going to be part of the secretions that enter the duodenum just prior to the chyme entering the duodenum. It's released into the small intestine only with the contraction of the gallbladder. Okay, so that CCK signal, this cholecystokinin signal, causes the squeezing of that sac on the underside of the liver, and it's the movement of the bile into the small intestine through the hepatopancreatic sphincter that takes with it a significant amount of pancreatic juice, and so mass action. Gallbladder contraction is stimulated by CCK, which comes from intestinal cells that have been exposed to the acidic fatty chyme. Vagal stimulation is also a minor stimulus. Okay, remember that the vagus nerve, parasympathetic division of the autonomic nervous system, has as one of its properties the stimulation of GI motility, the rest and digest division. CCK also causes secretion of pancreatic juice, and it allows the hepatopancreatic sphincter to relax so that the pancreatic juice and the bile can enter the duodenum. So once that mixes with the chyme, we neutralize the hydrochloric acid because of the strong bicarbonate content in the pancreatic juice, and then we also begin now the sequence of events that is eventually going to activate the proteases that are part of pancreatic juice so that they can begin to break down the protein. Remember that the lipases and the carbohydrases are already in their active form. CCK induces secretion of an enzyme-rich pancreatic juice by the acinar cells of the pancreas, and secretin causes secretion of a bicarbonate-rich pancreatic juice by the duct cells. And so when both of these act together, we get essentially an enzyme-rich, bicarbonate-rich, and bile-rich secretion that is prepared now to digest the chyme all the way down into its monomeric components. Vagal stimulation also causes the release of pancreatic juice. It is considered to be a minor stimulus. So if we look at the sequence of events here, what we're looking here is at mission critical for the GI, right? The secretions of three organs all impinge on the duodenum. That's why the duodenum is so important, such a critical area for digestion to go smoothly. The chyme enters the duodenum and causes the duodenal enteroendocrine cells to release CCK and secretin. Okay, so you can see that here as the pyloric sphincter opens up. The minute this stuff hits these cells, then that endocrine signal is sent. Okay, the cholecystokinin and the secretin enter the bloodstream, and this induces the secretion of pancreatic juice, and secretin causes the secretion of bicarbonate in the pancreatic juice as well. Okay, so the combined action of these two is going to control the composition of the pancreatic juice. At the same time, bile salts and secretin are transported to the bloodstream, and this stimulates the liver to produce bile rapidly. Cholecystokinin, which is carried by the bloodstream to the liver, causes the gallbladder to contract and the hepatopancreatic sphincter to relax. So it's a coordinated action. The bile then enters the duodenum along with the pancreatic juice. During the cephalic and gastric phases, vagal nerve stimulation causes the gallbladder to contract weakly as well. Okay, so um, the cephalic phase, remember, is where we actually acknowledge that there's food around, we anticipate a meal, and so secretions begin. And in the gastric phase, what's happening is that the food is actually in the stomach, okay, and this allows now the gallbladder to contract weakly, allows a little pancreatic juice to enter the duodenum, and as we said, prepare now this area of the GI for the entry of the chyme. Okay, and when the chyme actually comes, then we get a full force contraction of the gallbladder and an introduction at the same time of large quantities of pancreatic juice. Chyme from the stomach contains partially digested carbs and proteins and undigested fat. After about 3 to 6 hours in the small intestine, most of the water has been absorbed back into the bloodstream and about all the nutrients have been absorbed. And all you're left with then are the waste products. The small intestine has no role in ingestion or defecation. Its only purpose is the absorption of nutrients, electrolytes, and water across the lining of the GI, the lining of the small intestine, and into the blood. And then that nutrient-rich blood is carried by the superior and inferior mesenteric veins, ultimately fusing with the hepatic portal vein, which fuses with the hepatic artery, and then that blood that enters the liver is now subjected to an adjustment in its chemical composition by the action of the hepatocytes that line the sinusoids inside the liver. Remember when we looked at liver structure last Saturday, and we saw the hexagonal arrangement of the hepatocytes and the sinusoids and the triads that sit at each vertex of the hexagon, right? You've got at each corner of the hexagon, of which there are 6 corners, you've got a bile ductule, and you've got a branch of the hepatic artery and a branch of the hepatic portal vein. Okay, all of that made up a triad. Slow delivery of acidic hypertonic chyme and delivery of bile, enzymes, and bicarbonate ions from the liver and pancreas are then mixed in the duodenum, remember, as a result of the plicae circularis, which can undulate, the villi, which can undulate, and the peristaltic contractions of the small intestine. So we have to thoroughly mix all of these components in order for chemical digestion to occur at an appreciable rate. If we didn't do that, then the enzymes would just kind of sit around and you would have minimal chemical breakdown of your food. Segmentation is the most common motion of the small intestine. It's initiated by intrinsic pacemaker cells and mixes and moves the contents towards the ileocecal valve, which, as we're going to find out, is the doorway to the large intestine. The intensity is altered by long and short reflexes as well as by hormones. Parasympathetic stimulation increases the intensity while sympathetic stimulation decreases the intensity. And remember just the nicknames for these 2 divisions of the autonomic nervous system if you want to keep in your head what promotes and what retards GI motility, right? Parasympathetic division, rest and digest. Sympathetic division, the fight or flight division. This wanes in the late intestinal phase, and what we're looking at here is actually a peak at the microvilli that form the brush border of the small intestine and the absorptive cells underneath. These are basically mucus granules. These are mucus secretions, which helps again to lubricate the food and protect the lining of the GI. And remember that the purpose of these microvilli, as we talked about last Saturday, is to increase surface area so that we can perform sufficient biochemical work to aid the chemical process of digestion. Remember that we've got several modifications of the GI that increase surface area. We've got the actual folding of the intestine upon itself, okay, inside the abdominal pelvic cavity. We've got the plicae circulares, which are the ridges that make up a lot of the grooves and infoldings that line the small intestine, and then we've got the villi that line those plicae circulares, and then here we've got the microvilli that line the villi. So you've got now 4 levels of increasing surface area that are going to help in the digestive process. Peristalsis is the smooth muscle contractions that move the food through the pipe, and it's initiated by a rise in the hormone motilin in the late intestinal phase, and these waves occur every 90 to 120 minutes, and each wave starts distal to the previous wave. This is basically a migrating motor complex. It's triggered by, again, autonomic stimulation of the enteric nervous system, which in turn causes these smooth muscle contractions. Meal remnants, bacteria, and debris are moved to the large intestine. The trip from the duodenum to the ileum takes 2 hours on average, and here you can see a look at how peristalsis is designed to work. Adjacent segments of the alimentary canal contract and relax. Remember that the middle lining, the middle jacket of the small intestine is made up, dominated by 2 layers of smooth muscle, a circular and a longitudinal layer. What they do is they alternate in their contractile force, and that's what helps to propel the food down the pipe. Locoenteric neurons also coordinate intestinal motility. The cholinergic sensory neurons activate the myenteric plexus. This causes contraction of circular muscle proximally and longitudinal muscle distally, as we just discussed, and it forces the chyme to move along the tract. The ileocecal sphincter will relax and then permit the chyme to enter the large intestine when the gastroileal reflex enhances the force of segmentation in the ileum. And that's basically a smooth muscle reflex that occurs shortly after eating, within half an hour, 45 minutes on average. And also when gastrins increases the motility of the ileum, which is again the last part of the small intestine. The ileocecal valve flaps close when the chyme exerts backward pressure, so it's a one-way valve, and this is to keep regurgitation of waste products into the small intestine. The large intestine is a completely different aspect of digestion. There's not much nutrient absorption that happens in the large intestine. Primarily, what's in the large intestine are waste products, and the job of the large intestine is to adjust the fluid content of the fecal material. In the large intestine, you also have to remember that there are significant numbers of bacteria which degrade our waste products and produce some helpful byproducts as a result of this process, such as vitamin K and certain B-complex vitamins that we absorb into the bloodstream that help with metabolic function and blood clotting, just to name a few. Unique features of the large intestine include the Teniae coli, which are 3 bands of longitudinal smooth muscle in the muscularis. This represents the totality of the smooth muscle in the large intestine. Is basically an atrophied version of the muscularis layer in the small intestine. It's much less powerful and it's much less extensive, but again, the trip here is very short, and we don't want to do a lot of mixing. We don't need to. All we want to do is promote mass movements, and so this smooth muscle is sufficient to the task. The haustra are the pocket-like sacs that result from the contraction of these Teniae coli, and the epiplotic appendages are simply fat-filled pouches of visceral peritoneum that extend from the Teniae coli. The different regions of the large intestine include the cecum, which is the first portion of the large intestine, the appendix, which hangs just below it, the colon, which has several parts, an ascending, a transverse, a descending, and a sigmoid colon, followed by the rectum, and then the anal canal, and then that's the end of the trip. And so here you can see these different regions, and you can get an idea what these things look like. So let's start here with the ileocecal valve right here. This is where the ileum joins the large intestine. As the waste products move into this pouch, okay, they now enter the cecum. There is the appendix. The appendix is basically a piece of lymphatic tissue. Occasionally the appendix can become impacted with fecal material, which can cause it to swell as gas generates inside it, and then it has danger of bursting. And so this is why very often appendectomies are performed in individuals that have appendicitis, because if we were to introduce fecal material into the abdominal pelvic cavity, we would induce peritonitis, which could lead to septicemia, which could lead to death. Okay, as the Taenia coli contract, the fecal material is moved up the ascending colon. Okay, you can see the Taenia coli here. I'm tracing them. Okay, and the epiplotic appendages that hang from them, the little yellow fat sacs here. As we move up the ascending colon, we get to the right colic flexure. We head across the transverse colon to the left colic flexure, and then we descend the descending colon. We enter now the sigmoid colon, sigmoid meaning S-shaped, and then we get to the rectum and the anus. A lot of the large intestine is held in place by mesentery. This is the transverse mesocolon here. It's a type of mesentery that suspends the transverse colon, and the superior mesenteric artery you can see here is what supplies oxygen and nutrients to this connective tissue. Other important features to note there, you can see here behind there, just giving orientation, there's the common iliac artery. Okay, there is the abdominal aorta, and then here you can see the superior mesenteric, and of course the inferior mesenteric is going to be below that. Okay, so it's all basically connective tissue here. This brings up an excellent point, though. It's one that we've talked about already, the fact that most of your abdominal pelvic organs are held in place in the abdominal pelvic cavity by connective tissue, and as a result, it's very easy with a powerful blow to this region to dislodge these organs. So this is one of the most vulnerable parts of the human anatomy. You can also see here the haustra. Wanted to point those out as well. Okay, so that's the large intestine. The small intestine would sit right here. Okay, we've removed it so that you can see the connective tissue behind it, and you can see the large intestine, which basically forms a frame around the small intestine. Notice that it's very short, okay, and notice that it has very little surface area, and notice that it's not terribly muscular. So the cecum is the first part of the large intestine, and the appendix hangs inferior to it. It's a massive lymphoid tissue, and it's part of the MALT of the immune system. What does MALT stand for? Mucosa-associated lymphatic tissue. Okay. Again, we see here an excellent design on the part of the body, right? By stationing lymphoid tissue in an area where it's likely to run into pathogens, we ensure, or at least we help ensure, the likelihood that we're not going to get sick. It is a bacterial storehouse. It can recolonize the gut when necessary. Occasionally, you may, for instance, as a result of some sort of medical intervention, let's say be treated with a broad-spec antibiotic, which may deplete your gut bacteria. This could wipe out a lot of the E. coli in your large intestine, but because we have now these sort of reserve bacterial cells in the appendix, we have the potential to recolonize the gut. If it gets twisted, the enteric bacteria can accumulate and multiply, and that can result again in appendicitis, which could result in a ruptured appendix. leading again to peritonitis, to septicemia, and then perhaps even to death. The colon is a retroperitoneal organ, except for the transverse and sigmoid regions, so it lies behind the peritoneum mostly. The ascending colon runs from the right side to the level of the right kidney, and then it turns at the right colic flexure, which is near the liver. That's why it's called the hepatic flexure. The transverse colon then moves across to the left side of the body where it bends at the left colic flexure or splenic flexure, so called because it's near the spleen. And then the descending colon heads down the left side where it eventually will hit the sigmoid colon in the pelvis, which will then head to the rectum and the anus. And so what we're doing here is this is an unusual view of the intestine. What we've done here is we've reflected the greater omentum, which is a large piece of fatty connective tissue that hangs in front of the large and small intestine. You probably know it better as your beer gut. Okay, and we've revealed here underneath the portions of the large intestine, but we've also left in place the small intestine. And so what you can see here again are the connective tissue formations that sort of hold this in place. The transverse mesocolon, of course, attached to the transverse colon. You can see the sigmoid mesocolon down here, and then you can see large amounts of mesentery that hold the small intestine in place. This is just to bring home the point that basically what holds the lower GI in place is connective tissue, okay? Extensive amounts of connective tissue. Throughout this connective tissue are running arteries and veins and considerable numbers of lymphatics as well. Okay? Remember that the drainage of the mesenteric arteries from the walls of the small intestine is eventually what conveys now the nutrient-rich blood to the liver. Okay, so you can see basically all these features here. This is just a sagittal view of the same thing. Okay, so you can pick up where each of these pieces of connective tissue are to orient you. There's the greater omentum, okay? And then back here, you can see here the lesser omentum that connects the liver to the stomach. Okay, so the greater omentum, the lesser omentum. Transverse mesocolon, which basically connects to the transverse colon, attaches it to the posterior body wall. And then you can see the peritoneal membrane all through here, right? Peritoneal membrane is indicated here by this green outline, the visceral peritoneum by this sort of electric blue outline here. Okay, so the visceral peritoneum runs all along the outside of the duodenum, the jejunum, and the ileum. The parietal peritoneum, of course, lines the body cavity, and so you can see why, when the appendix ruptures, we worry about peritonitis. Okay, you can see the extent of this membrane all throughout the body cavity. There's a duodenum up here. See, the duodenum lies behind the peritoneal membrane, while the rest of these guys have the visceral peritoneum all around them. So duodenum behind the parietal, and the rest of the small intestine lined by the visceral. Okay, so that's just an idea to give you, let you know approximately where these organs are in sagittal section. There's the rectum and the anus. Okay, there's the anus, the rectum, and there is the last portion of the sigmoid colon. Okay, there's the urinary bladder and the urethra, and there's the liver, the stomach, the transverse colon, and then of course over there the duodenum, just to give you an idea of what you're looking at. Okay, the rectum has 3 rectal valves that stop feces from being passed with gas. The anal canal is the last segment of the large intestine and opens to the body exterior at the anus, and there are several sphincters that control the passage of fecal material through this region. There's the internal anal sphincter, which is made up of smooth muscle and as a result is involuntary, and the external anal sphincter, which we control, made up primarily of skeletal muscle. And you can see these structures here. Okay, so there is the rectal valve. Okay, you can see the rectum proper. You can see here the the anal columns. Okay, there's the internal anal sphincter and the external anal sphincter. So this is all skeletal muscle here. Okay, and this is smooth muscle here and here. And then what you probably also noticed right away were these hemorrhoidal veins. Okay, now people laugh about people who suffer from the condition known as hemorrhoids, which are basically these veins protruding into the anal canal and sometimes outside the rectum. And they itch, they're uncomfortable, but they're also dangerous. And the reason they're dangerous is because of their location. Because if they bleed, it's very easy to get bacteria into the blood, and that can result, again, in septicemia. Okay? There is the levator ani muscle here. Okay? This helps to lift the anal canal up. This is how we actually cause the feces to drop away. And essentially, I think that takes care of it. If we look at the microscopic anatomy of the large intestine, the thicker mucosa of simple columnar epithelia is found in the anal canal, except towards the end we see stratified squamous epithelia, and that's there primarily to withstand abrasion. And so what you see here with the mucosa is a tissue that's going to lubricate the fecal material so it's easier to pass. And the stratified squamous, basically any stratified tissue is going to be tougher than its simple counterpart, and as a result is going to stand up better to mechanical stress and strain. And so, again, an excellent design on the part of the body. There are no circular folds, no villi, and no digestive secretions, and there's deep crypts with goblet cells that secrete the mucus into the large intestine. There's also a superficial venous plexus in the anal canal that, again, can form hemorrhoids if it is inflamed, and we talked about those. Now, you have a resident inside your colon. These are the E. coli. They're named for where they live. E. coli stands for Escherichia coli, and these are rod-shaped bacteria. They are normal flora. Okay, they enter from the small intestine or the anus as soon as we're born, and they colonize the colon, and they synthesize B-complex vitamins and vitamin K. Vitamin K is vital in blood clotting. The B-complex vitamins are important in metabolic reactions. They also help with the production of mucin, heparin, and hyaluronic acid. Basically, hyaluronic acid is a major component of extracellular matrix tissue. Heparin is an anticoagulant, and mucin is, again, primarily there to, I'll have to get back to you on that. Let me double check. Okay, these bacteria ferment indigestible carbohydrates. What does that mean? Fermentation is just the breakdown of organic components in the absence of oxygen. They release irritating acids and gases, about a half a liter a day on average. There's also intestinal flora. Viruses and protozoans are sometimes found in this region of the body. Viruses, remember, are non-living pathogens. They're essentially a protein coat around genetic material, and their role primarily is to infect healthy tissue and cause them to inflame and turn into virus factories, which in turn assemble new virus particles that go out and infect other tissue. Protozoans are single-celled eukaryotic organisms. Many of these are parasites, and they can cause a wide variety of diseases, among them dysentery. The bacteria are prevented from breaching the mucosal barrier. The epithelial cells recruit dendritic cells. Remember, those are a component of the lymphatic system. These head to the mucosa, and they sample microbial antigens and present them to the T cells that lie in the mucosa-associated lymphatic tissue. And this promotes the production of IgA antibodies and restricts the entry of microbes into the deeper tissues. Again, an excellent design on the part of the human body to put the lymphatic tissue where it's most likely to encounter now pathogens. The residue that enters the large intestine remains there between 12 and 24 hours. There's no food breakdown except by the bacterial occupants of the colon, and vitamins, water, and electrolytes are then reclaimed during this period of time. The major functions include propulsion of feces to the anus and then the act of defecation. Your colon is not essential for life. In fact, in individuals that either have a functional or physical blockage of the colon that requires that that portion be resected, sometimes we can bypass um, a non-functioning region that links to the rectum and the anus by doing something called a colostomy, where basically we intercept the fecal material upstream of the block, whether it be functional or physical, and then that's a bag that can be swapped out. Basically, is a bypass that goes directly into the colon. Most contractions of the colon produce haustra. These are slow segmenting movements. They sequentially contract in response to being stretched. The gastrocolic reflex is initiated by the presence of food in the stomach, and it activates 3 to 4 slow, powerful peristaltic waves daily, and these are what we call mass movements. Okay, now if we consider conditions that can cause the digestive system to malfunction, what we're looking at are homeostatic imbalances. As an example, a low-fiber diet can result in a narrow colon because a low-fiber diet lacks sufficient bulk to distend the colon. This can lead to strong contractions and increased pressure on the walls, and this can create diverticula, which are essentially outpouchings of the mucosa of the intestine, inside which bacteria, food, fecal material can get trapped. And these can become inflamed and can produce now a condition known as diverticulitis. So diverticulosis is an example of this condition. Diverticulosis is simply the appearance of these blind pouches along the colon. It's very common in the sigmoid colon, but it can occur anywhere in the large intestine. It can also occur in the small intestine. And essentially these represent areas for material to get trapped. It affects half of the people over the age of 70 years. So this is a condition that's probably coming down the pike for a significant percentage of the population as we age. Diverticulitis is where these pouches become inflamed. They have the potential to rupture and leak into the peritoneal cavity, and this could be life-threatening. You could think of this as having multiple appendices. Remember that the appendix is essentially a blind sac at the cecum, where the ileum of the small intestine joins the large intestine. It can become filled with fecal material, and the bacteria can, as they ferment that material, produce gas and distension and can cause the sac to inflame and perhaps burst. And it's the same thing that you're looking at in individuals who suffer from diverticulitis.
Hi, my name is Dave Larson. I'm one of the consultants in colorectal surgery here at the Mayo Clinic, and I'm talking to you today about diverticulitis. I just wanted to mention that here at the Mayo Clinic Rochester, we have many new and novel surgical interventions for the treatment of diverticulitis, with, of course, the goal of less pain, early recovery, and, of course, a minimally invasive approach. Before we go any further, I'd like to talk to you about definitions of diverticulitis. They, of course, occur with the issue of diverticulosis, which is an outpouching of the colonic wall. Outpouchings can occur anywhere along the GI tract, however, are most commonly seen in the large intestine. Patients who experience diverticulitis will often experience left lower quadrant pain, nausea, fever, possibly even vomiting, and oftentimes diarrhea or constipation. The treatment algorithm for diverticulitis spans the gamut from medical treatment, which would be antibiotics or fiber, to surgical therapy. Thankfully, most patients do not require surgical therapy. Most patients can be treated successfully with antibiotics and or fiber. Risk factors for diverticulitis include old age. It also includes the lack of exercise and a low fiber diet. In terms of diagnosing yourself with diverticulitis or diverticulosis, unfortunately, if you're over the age of 40, you likely have diverticulosis. Most patients, as we age, develop these outpouchings within our colon and are most commonly diagnosed during your screening colonoscopy at age 50. Diverticulitis, being an acute event, is typically diagnosed by your doctor through a physical exam or very commonly through imaging modalities, which we have here at the Mayo Clinic called CT scans or CAT scans. These images help to define the inflammatory condition within your colon and aid the surgeon in determining what surgical procedure to perform. There is no doubt that for those of you with diverticulosis, this is a disease process that is simply treated with medication and diet. For those patients with diverticulitis, there's no doubt that you may have suffered for a period of time. You may have had recurring events over the last few years, or you may have what we would call smoldering disease and continue to have pain or disability from your diverticulitis. These operative interventions include laparoscopic assisted procedures, hand-assisted procedures, and robotic procedures, which are all minimally invasive. These operations in general leave you with small scars, lead to little disability, and very short hospital stays, typically around 3 days. We have a great experience with both laparoscopic, hand-assisted, and robotic techniques here at the Mayo Clinic, and have literally seen and performed thousands of operations.
Now, irritable bowel syndrome, or IBS, is a functional GI disorder. It's characterized by recurring abdominal pain, stool changes, bloating, flatulence, which is intestinal gas, nausea, and depression. Stress is a common precipitating factor, so stress management is important in the treatment of this particular condition. This falls under an umbrella of diseases that we might call idiopathic, meaning we don't have a real defined set of causes. We do know some factors that exacerbate the condition, but we can't definitively say what causes it in the first place, because not everybody who experiences stress experiences the condition of IBS.
Irritable bowel syndrome, or IBS, is a chronic condition affecting your large intestine. Your large intestine, also known as your colon, includes the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. The muscular wall of your colon contracts in a rhythmic fashion called peristalsis to move the intestinal contents toward your rectum. As it contracts, your colon absorbs water and nutrients from partially digested food moving through it. Waste material, called stool, is stored in the rectum until it is expelled through the anus as a bowel movement. With IBS, the muscular contractions of your colon are abnormal. In some cases, the contractions may cause food to move too quickly through your colon. As a result, your colon does not have enough time to absorb most of the water from your food. This condition leads to a watery stool and diarrhea. In other cases, the contractions may cause food to move too slowly. As a result, your colon absorbs too much water from your food. This condition leads to a hardened stool and constipation. It is unclear why your colon contracts abnormally. However, if you have IBS, your colon may be more sensitive to certain factors such as stress that seem not to affect most people. Other symptoms of IBS include abdominal pain and discomfort, bloating, gas, and cramping. You can manage your IBS symptoms through a combination of dietary habit changes, stress management, and medications. Eating food high in fiber creates softer, bulkier stools, which may prevent spastic colon contractions. Fiber also helps relieve constipation. Stress management therapies, such as hypnotherapy and yoga, may help relieve your symptoms. Your doctor may prescribe medications to help manage your symptoms, such as anti-constipation drugs to help regulate your bowel movements, antispasmodic drugs to minimize muscle spasms and reduce pain, or sedatives and antidepressants to relieve anxiety and elevate your mood.
Okay, defecations are mass movements that force the feces towards the rectum. By the time the food has reached the cecum, most of the nutrients have been absorbed into the bloodstream and are headed towards the hepatic portal vein and from there into the liver. What's left behind in the intestine is waste material. Most waste material are molecules that we can't digest. Examples would include cellulose, which we know of as wood. We consider this part of the fiber content of our diet. And there is a very important function to fiber, which is that it adds bulk to the stool and it increases GI motility. So it makes it easier to pass fecal material. So these mass movements force the feces towards the rectum. Distension initiates a spinal defecation reflex. The parasympathetic division of the autonomic nervous system stimulates contraction of the sigmoid colon in the rectum, and they also relax the internal anal sphincter, which again is a ring of smooth muscle that encircles the rectum. Once that relaxes, we can relax the external anal sphincter, and then we can void the fecal material. So conscious control allows us to do that. What are the muscles that are used in order to perform this activity? They're the muscles that we associate with something called the Valsalva maneuver. Basically, we close the glottis, that's the opening between the vocal cords. We contract the diaphragm and the abdominal wall muscles, and this increases the pressure in the abdominal pelvic cavity. And this presses on the rectum, and this can force, along with the contractions of the Teniae coli, the fecal material eventually towards the rectum and the anus. The levator ani muscle will then contract, the anal canal will be lifted superiorly, and then the feces will leave the body. And this is just an illustration of how this reflex operates. So here you can see in the first step the feces moving into the rectum. This causes it to distend. That means that it stretches out. And this stimulates stretch receptors in this region, and they transmit signals along afferent fibers to the spinal cord neurons. The next step is that a spinal reflex is initiated, which parasympathetic motor neurons facilitate. These fibers stimulate contraction of the rectum and the sigmoid colon and the relaxation of the internal anal sphincter. Now, what I want you to notice about this is that this does not involve any higher nerve centers. It doesn't involve the brainstem, doesn't involve the cerebral cortex at all. This is why individuals who are paraplegic or quadriplegic can still execute the defecation reflex because it's mediated by the spinal cord alone. And then finally, if it is convenient to defecate, voluntary motor neurons are inhibited, and this allows the external anal sphincter to relax so that the feces are able to pass. Okay, so you can see here where the external anal sphincter is located. You can see the innervation here. This is skeletal muscle. Okay, so this is coming down from the brain. The internal anal sphincter here is innervated primarily by parasympathetic neurons, and this is smooth muscle. Okay, so internal anal sphincter and external anal sphincter. and then the feces is able to pass. Now, there's a condition that can affect the rectum and the anus that sort of goes hand in hand with this activity. If the fecal material is too compact and you strain in order to void, this can cause hemorrhoidal veins to protrude into the rectum and the anus. And the problem here is not only are these extremely uncomfortable, but they present an infection risk because of their location. If they bleed, the bacteria that are resident in the colon can enter the bloodstream, and this can cause septicemia. It's a very dangerous condition indeed. So if you suspect you have a hemorrhoid, you definitely want to have your proctologist check that out, or your GP. Okay, if we're considering chemical digestion, this is a series of enzymatic reactions that's designed to break the macronutrients that we consume into small enough chemical components that we can absorb them into the bloodstream, transport them to the liver, and then from the liver to the rest of the body to be used for energy. These are catabolic reactions. The enzymes that facilitate this are created by the accessory glands of the digestive system and also by the lining of the small intestine and the stomach, just to name a few of the very important organs. So the salivary glands have a role here, the gastric lining has a role here, the gastric mucosa, the liver and the pancreas have a role, and the lining of the small intestine, the brush border enzymes, have a role as well. So intrinsic and accessory glands help to break down the food. This is performed primarily by hydrolysis. Hydrolysis is just a term meaning using water, hydro, in order to split, lysis, the macromolecule into smaller pieces. And again, the reason this is important is because if we don't do this, if we don't break these macromolecules down into tiny enough pieces, we're not going to be able to absorb them across the wall of the small intestine and get the nutrients into the bloodstream. Only monosaccharides can be absorbed if we're considering carbohydrate digestion. They are absorbed directly as ingested. Examples include glucose, fructose, and galactose. Digestive enzymes such as salivary and pancreatic amylase and the brush border enzymes dextranase, glucosamylase, lactase, maltase, and sucrase help to break down polysaccharides. Okay? In the case of lactase, maltase, and sucrase, what we're breaking down are disaccharides, and in the case of these other enzymes, we're breaking down polysaccharides, basically more than two sugar molecules hooked to each other. In individuals that lack some of these enzymes, what can happen is that the disaccharide can persist and make it all the way to the large intestine, where the resident bacteria can use it as a fuel source, producing massive amounts of gas and generating distension and pain and leading to conditions such as diarrhea. Individuals, for instance, have lactose intolerance, lack this particular enzyme, and as a result, they have to avoid dairy products, or they have to supplement their diet with this enzyme in the form of a pill in order to break down lactose into its component parts, galactose and glucose, so that they can be absorbed directly into the bloodstream. So unless these larger saccharides, these disaccharides, polysaccharides, are broken down into monomers, we're not going to be able to realize now the fuel benefit from them. They'll remain in the lumen of the intestine. So let's start with starch digestion. It begins in the oral cavity. Salivary amylase breaks oligosaccharides into smaller components. Basically, glucose polymers are broken into maltose, which are glucose disaccharides, at around pH 7 or so. Pancreatic amylase breaks down any of the starch molecules that escaped the action of salivary amylase, again, in order to ultimately absorb the monosaccharides into the bloodstream. Brush border enzymes such as dextranase, glucosamylase, lactase, maltase, and sucrase act on oligosaccharides, breaking them down into monosaccharides, and these are then absorbed directly into the bloodstream. And it's only then that we can transport them to cells that need them for metabolic energy so that they can generate sufficient ATP in order to perform life activities. And this is just a peek at the different carbohydrates that we ingest, where the enzyme that digests them is produced, where it acts, and what the end products are. And the bottom line here is that we want to eventually get to these monosaccharides so that we can absorb them directly into the bloodstream. Okay, proteins represent a particular challenge because proteins are polymers of amino acids, very long polymers. And in order to absorb the nutrient content of protein, we need to break them into their component amino acids. The source of protein in our diet is primarily meat, but it does come from other sources. There are significant amounts of protein in vegetables and fruits as well, although not as much as in sources of animal nutrition. Digestive enzymes and mucosal cells have enzymatic components that are designed to break down these proteins into their amino acid monomers. It begins with pepsin in the stomach. Pepsin has its pH optimum between 1 and 3. As a result, the acidic environment of the stomach represents the perfect place for pepsin to begin the degradation of protein. It's actually produced as an inactive form, pepsinogen, by the chief cells of the gastric mucosa, and then what happens when it hits the acidic environment of the stomach is that hydrochloric acid, along with previously activated pepsin, will cleave covalent bonds in this zymogen and turn it into the active protease. And the reason for that is that we don't want the pepsin to be active prematurely because it would digest the cell that creates it. So this is a way of delaying the activity until the food actually arrives. So we want the enzyme to be active where and when we designate. It becomes inactive when it enters the duodenum because of the introduction there of bicarbonate from the pancreas. Pancreatic proteases include trypsin, chymotrypsin, and carboxypeptidase, which again are also produced as inactive zymogens in the pancreas, but once they hit the lumen of the duodenum, the brush border enzymes will cleave particular covalent bonds to generate now the active forms of the enzymes listed here. And the strategy is the same. We don't want these proteases active inside the gland that produces them because it would digest the gland. And so we delay the activation until we hit the lumen of the duodenum, and at that point the chyme from the stomach and the pancreatic juice will mix effectively, and the enzyme will be activated and ready to break up the protein that's in the food that we eat. Brush border enzymes are also present, and they help to further break down the oligopeptides that are produced by the combined action up to this point of pepsin, trypsin, chymotrypsin, and carboxypeptidase. These include aminopeptidases, carboxypeptidases, and dipeptidases, and their activity is primarily aimed at short stretches of amino acids with the idea that we break them down into individual amino acids for transport into the bloodstream across the wall of the small intestine. And so what you're looking at here is just a diagram showing you these brush border enzymes and how they do their tricks. Okay, so this is the lumen of the duodenum. These are the pancreatic proteases. They become activated when brush border enzymes and other activated pancreatic proteases cleave particular bonds, and then they begin the process now of degrading these polypeptides into their component amino acids. At that point, we have active transport of amino acids using a sodium amino acid symport. So this is the ATP-dependent process to pump these amino acids into the epithelial cell and then straight across the basal surface directly into the bloodstream. And at that point, we can carry this amino acid directly to the liver, where it will decide what to do with it next. What you're looking at here are, again, the different organs of digestion and their role in the breakdown of protein. Okay, so You've got the stomach here with the production of pepsin and hydrochloric acid, the pancreas with its production of a series of zymogens which become activated by the brush border enzymes of the duodenum of the small intestine, and those activities combined with the brush borders enzymes that are present in the small intestine break the proteins into their component amino acids, and then they're absorbed across the lining of the small intestine, and then they enter the capillaries that lie just beneath the lining of the small intestine, and from there they're carried to the hepatic portal vein for entry into the liver. Okay, lipids are a little different. Lipids present a challenge because of their size and because of their hydrophobicity. So there are two secretions that help us to break down the fat component in the food that we eat, and that's the bile that comes from the gallbladder, and then the lipase that comes both from the salivary glands and from the pancreas. So when we're in the stomach, the fat that's in the stomach is going to enter with the chyme into the duodenum. At that point, bile salts will be introduced into the duodenum via the gallbladder, and this helps to emulsify these large fat droplets into tinier droplets so that the lipase that's coming from the pancreas can effectively break down the fat. Once the lipase acts, the fats are broken down into fatty acids and monoglycerides, and then we have absorption of glycerol and short-chain fatty acids right across the lining of the small intestine. They're absorbed into the capillary blood in the villi, and then they're transported via the hepatic portal vein directly into the liver. Okay, so you can see here how it is that we deal with these this particular macronutrient. Okay, the fat globules coming into the duodenum with the chyme from the stomach. The bile salts emulsify these globules into smaller fat droplets, and then what happens here is that they get coated by the bile salts, and lipase then degrades these fats into monoglycerides and free fatty acids, and these form micelles, which then are transported to the intestinal mucosa. Micelles contain fatty acids, monoglycerides, and bile salts, and they represent a form of cholesterol called bad cholesterol. Okay, you've probably heard of bad cholesterol and good cholesterol. The fatty acids and monoglycerides leave the micelles and they diffuse into the epithelial cells. They are then recombined with other fatty substances and proteins to form chylomicrons, which are extruded from the epithelial cells by exocytosis. Again, this is active transport. And then these enter the lacteals that lie just below the villi and are carried away from the intestine in the lymph. Where they go next is that they're going to rejoin the circulation, ultimately at the area where the lymphatic system and the circulatory system reunite, and that's near the subclavian veins, the right and left subclavian veins. And from there, we'll ultimately find our way back to the liver. And so, again, this is just showing you the different accessory organs of digestion and their role in the breakdown of fat. So you've got lingual lipase from the salivary glands, gastric lipase from the lining of the stomach, the bile salts, which of course emulsify the fat droplets. The bile salts are manufactured in the liver and stored in the gallbladder. And then the pancreatic lipases, which act in the small intestine to break down the triglycerides into monoglycerides and free fatty acids, and ultimately generate the chylomicrons that get absorbed into the lacteals, which then transport the fat components ultimately back to the circulation where the lymphatic system and the circulatory system rejoin. Nucleic acids are digested by enzymes such as deoxyribonucleases and ribonucleases. These are synthesized by the pancreas, and they break down this material into monomers. Brush border enzymes are also active in this regard. They are capable of breaking the sugar phosphate backbone in RNA and DNA and generating now the free bases and the ribose or deoxyribose sugars and the phosphate ions that are now going to be absorbed into the capillaries and from there head to the liver. And so what you're looking at here is again the role of the accessory organs of digestion and the small intestine in the digestion of nucleic acids. Pancreatic ribonucleases and deoxyribonucleases help to break down oligonucleotides in the duodenum, and the brush border enzymes break down the oligonucleotides into their component parts, the sugars, the phosphates, and the free bases, and then those are absorbed directly into the capillaries where they eventually head to the hepatic portal vein and from there to the liver. About 80% of the electrolytes, all of the food, and most of the water is absorbed in the small intestine. Most of this occurs prior to the ileum, so the jejunum is where most of this happens. The ileum reclaims the bile salts, and those are then transported back to the liver. Most is absorbed by active transport via the blood. The exception being the lipids, because they have to enter now the lymphatic system via the lacteals and then rejoin the circulatory system at a different location. Glucose and galactose are absorbed by secondary active transport with sodium through the epithelial cells that line the small intestine. Move out of the epithelial cells by facilitated diffusion into capillary beds that are just beneath the villi. Fructose moves by facilitated diffusion to enter and exit cells. Facilitated diffusion, remember, works with the concentration gradient that requires a protein carrier in the membrane in order for the molecule to be able to move across that barrier. Glucose and galactose are moved by secondary active transport with sodium into the epithelial cells and then again by facilitated diffusion into the villi, and fructose again by facilitated diffusion to enter and exit the cells as well. Okay, protein is broken down into amino acids, which are transported by several different types of carriers. Most are coupled to the active transport of sodium. Dipeptides and tripeptides are actively absorbed by a proton-dependent cotransport. They're digested to amino acids within the epithelial cells, and then they enter the capillary blood by diffusion. Occasionally, we can have homeostatic imbalance with regard to absorption and secretion. This can affect the digestive system, in particular the small intestine. Whole proteins are generally not absorbed. They can be taken up by endo and exocytosis, as is most commonly seen in newborns with the phenomena of food allergies. This usually disappears with the maturation of the mucosa. This allows IgA antibodies in the breast milk to reach the infant's bloodstream, and this provides passive immunity. So this is an unusual example of whole protein entering the bloodstream.
During an allergic reaction, the immune system responds to a normally harmless substance as if it were a threat. In some people, common foods such as milk, eggs, and peanuts can trigger such a reaction. So how does this work? If you have a food allergy, your immune system makes a type of antibody called immunoglobulin E, or IgE. This class of antibody binds to immune cells called mast cells and basophils that circulate throughout your body. When you are exposed to the food allergen, it attaches to the IgE antibodies. This binding signals the immune cells to release histamine and other chemicals that cause allergy symptoms, such as swelling of the lips, hives, and shortness of breath. Because mast cells and basophils rapidly release these chemicals, an allergic reaction typically occurs within 30 minutes after exposure. The most severe kind of reaction is called anaphylaxis, which can cause a sudden drop in blood pressure, trouble breathing, dizziness, and possibly death. People with food allergy and poorly controlled asthma are more susceptible to severe reactions. An anaphylactic episode must be treated with a hormone called epinephrine, which maintains blood pressure and opens up the airways. To deal with accidental exposure, people diagnosed with food allergy are prescribed a medical device called an autoinjector that delivers a single dose of epinephrine into the thigh muscle. Antihistamines alone are not an effective treatment for anaphylaxis. There is no cure for food allergy. The best way to manage the condition is to avoid the allergenic food, read food labels carefully, wash hands and household surfaces, and always carry an epinephrine autoinjector. If you are accidentally exposed to a food allergen, seek medical help immediately. The National Institute of Allergy and Infectious Diseases, or NIAID, conducts and supports research to better understand, prevent, and treat food allergy. In 2010, an expert panel sponsored by NIAID issued guidelines to assist healthcare professionals in diagnosing and managing the disease. These guidelines and a summary for patients, families, and caregivers can be found on the NIAID website.
Absorption of monoglycerides and fatty acids begins with the formation of micelles as a result of their interaction with bile salts and lecithin. These micelles are then released into epithelial cells, where they combine with lecithin, phospholipids, cholesterol, and are coated with proteins and form now chylomicrons, which enter the lacteals and are transported to the systemic circulation, where they're hydrolyzed to free fatty acids and glycerol by the lipoprotein lipase of the capillary endothelial layer. That's the layer of the capillary that comes into contact directly with the blood. Cells can then use the energy directly, or they can store it as fat. Short-chain fatty acids diffuse into the portal blood for distribution. For nucleic acids, we have active transport across the epithelium into the bloodstream. Vitamins are important cofactors in enzymatic reaction. You could consider them to be enzyme tools that are used in order to carry out particular chemical reactions, be they catabolic or anabolic in the body. And as a result, we need these in our diet in order for metabolism to continue. Vitamins can either be water-soluble or fat-soluble. The fat-soluble vitamins are A, D, E, and K, and the water-soluble vitamins are the B-complex vitamins and vitamin C. And so, depending on the chemical characteristics of the vitamin, the method by which it's absorbed into the bloodstream is going to be different. So in the small intestine, the fat-soluble vitamins are carried by micelles, where they diffuse into absorptive cells. The water-soluble vitamins are absorbed by diffusion or by passive or active transporters. B12 is an exception. It binds with intrinsic factor in the stomach and is absorbed by endocytosis. B12 is vital in hematopoiesis and in the production of DNA. A lack of intrinsic factor leads to a condition known as pernicious anemia that results in a decreased ability of the blood to carry oxygen because of a lack of red blood cells, and also a lower metabolic rate. In the large intestine, vitamins K and B are absorbed from bacterial metabolism. These are byproducts that the E. coli make as they break down the waste products that enter the colon, and they are then absorbed across the wall of the large intestine, where we use vitamin K, for instance, in blood clotting, and the B-complex vitamins are used in a wide variety of metabolic activities. Most ions are absorbed actively along the length of the small intestine. Iron and calcium are absorbed in the duodenum, and sodium is coupled with the active transport of glucose and amino acids. Chloride is also transported actively into the bloodstream, and potassium diffuses in response to osmotic gradients, and it can be lost if there is poor water reabsorption in the large intestine. This usually results in electrolyte imbalances. Usually the amount in the intestine is the amount that is absorbed. Iron and calcium absorption are related to their need. Ionic iron is stored in the mucosal cells with ferritin, which is a protein. When needed, it's transported in the blood by transferrin. Calcium has its absorption regulated by vitamin D and parathyroid hormone. Remember that parathyroid hormone has as one of its activities the acceleration of osteoclast activity and the demineralization of bone, and this has the effect of raising blood calcium levels. Activated vitamin D is also a vital component in this process. Activated vitamin D is a multi-step pathway. There are steps that take place in the kidney and in the skin under the influence of UV light that comes from the sun. Okay, 9 liters of water, most from GI tract secretions, enters the small intestine. 95% of this is absorbed in the intestine by osmosis. Most of the rest is absorbed in the large intestine. Net osmosis occurs if concentration gradients established by active transport of solutes are present. Basically, this follows the old rule that water will follow solutes. Water uptake, as a result, is coupled with solute uptake. The major mover primarily is sodium. The other ions also have an effect. So where the sodium goes, the water will follow. This is true in the kidney. This is true in the intestine. It's true throughout the body. Occasionally, we can have problems absorbing the nutrients into the bloodstream. The causes can be anything that interferes with the delivery of bile or pancreatic juice into the duodenum. You can also have a damaged intestinal mucosa as a result of infection or as a result of antibiotic activity. Celiac disease is an immune reaction to a protein called gluten that you find in wheat flour. This causes the immune cells to damage the intestinal villi and the brush border. It's generally treated by eliminating gluten from the diet. And the way you do this is avoid all flours except those made from rice and corn.
Patients with celiac disease come in all shapes and sizes and all ages, and it can present at any age. Well, celiac disease is a reaction of the immune system in the intestine to certain proteins, and the proteins come from wheat, barley, and rye. Those proteins, which we collectively term gluten, are generally considered something that is good for us, but for patients with celiac disease, and probably for some genetic reasons, their immune system reacts against it and sets up a inflammation or damage in the lining of the intestine. And that's where we are trying to digest and absorb the gluten, but rather what happens is the gluten proteins set up this reaction, and in that reaction you get damage to the lining of the small intestine. And the small intestine is lined, the normal small intestine is lined with villi. Villi are like finger-like projections, and they're there really to maximize the amount of working area we have for digestion and absorption. And it's been said that if you could iron out the small intestine completely flat, that it would cover a tennis court. Now, of course, in celiac disease, if you lose all those finger-like projections and you get damage and it ends up being flattened, so you end up with an intestine that instead of looking like a deep pile carpet, it looks more like a tiled floor, then you end up with a surface area that's substantially small, or maybe more like a tennis table top, but a much smaller working surface area. Now, we know that's from work that we've done here, that celiac disease affects a variable amount of the small intestine. In some patients, it's just 1% of the intestine. In others, it can be 60 or indeed 100% of the small intestine. And the consequences can be very variable. Some patients have terrific diarrhea, weight loss. If they're young children, failure to thrive. They may be anemic. They may have severe osteoporosis because of lack of vitamin D and calcium. They may have other consequences. If they may have grown to a shorter height than they would have achieved other than having celiac disease. It can affect the permanent teeth, and often dental loss is pretty common in patients with celiac disease. But there are other patients who don't seem to get those same symptoms. They get problems like anemia, where they've got low iron or low hemoglobin, and especially if they can't respond to oral iron. So their doctor tells them take iron, but they don't respond. It may be because they can't absorb the iron, and again, that can be a clue to celiac disease. The treatment is safe. Going on a gluten-free diet is a safe endeavor. It's not easy because of how pervasive wheat especially is in our diet, and there are many hidden ingredients that are made from that can be a problem for somebody with celiac disease. It's certainly not an easy diet, and not one that should be followed casually. A precise diagnosis is necessary to justify being on a gluten-free diet for life. It can be socially restricting. It can make it more expensive. It certainly is more expensive to adhere to a gluten-free diet because you have to source foods in special ways, either by mail order or from specialty suppliers or from manufacturers that take great care to avoid contamination of their food with gluten. So that's an area, and to be on a gluten-free diet doesn't just require, let's say, self-teaching, go on the internet, look for information, but to really requires a consultation with an expert dietitian, somebody with expertise in celiac disease. I think to summarize, the most important thing is if somebody suspects they have it, is to be tested before it's treated. The second thing is celiac disease is not a trivial disease. It can be associated with substantial complications. One thing we didn't mention is it had been thought maybe 20, 30 years ago that people who had celiac disease as children could outgrow it. That's not the case. If somebody had a diagnosis as a child, and they almost certainly still have the disease, and they should be gluten-free. So this is an area where we've got new data, new information. It is rapidly changing, but it's also one where I would see some hope for the future in terms of finding the people who have got hidden celiac disease, understanding what that means in terms of their health, and giving people the tools who have celiac disease to live better lives and to be feeling less socially restricted, and be able to live a essentially normal lifestyle with an interesting, varied, and healthy diet. If you have a family history of celiac disease, brother, sister, parent, or child with the disease, I think there's very good evidence that you should be tested for celiac disease. If you've got premature osteoporosis, certainly type 1 diabetes, it certainly should be considered. Patients with unexplained infertility, a whole host of other ways in which celiac disease can present. It can mimic irritable bowel syndrome, which is obviously much more common than celiac disease. Again, it's a question of once the disease is suspected, a test should be performed before the diet is altered. But the big challenge is getting people to think about the diagnosis.
Now, where does the digestive system come from? What is its embryonic origin? Well, it's basically derived from the endoderm. Remember that during embryonic development, one of the landmark events is the establishment of the three primary germ layers, the ectoderm, which gives rise to the epithelium and the nervous system, the mesoderm, which gives rise primarily to the musculoskeletal system, and the endoderm, which produces most of the internal organs. And that's sort of an oversimplification, but that's basically the lineage. So the oral membrane of the endoderm is eventually going to become the mouth opening, while the cloacal membrane will become the anus. By week 5, the alimentary canal is continuous from the mouth to the anus, and shortly afterwards, accessory organs will bud from the mucosa, and this will complete the genesis of the GI tract. And so here you can see the evolution of the digestive system. Here, this is the nervous system and spinal cord. That's eventually going to be the heart. This here is the midgut, and this is where the yolk sac would be located. Now what happens eventually is the yolk sac shrinks as the nutrients from the yolk sac are used for metabolic energy during development, but the remnants of the sac are going to form structures of the GI. The cloacal membrane, you can see down here near what's eventually going to be the anus. Okay, this of course is the body stalk that connects the embryo to the wall of the uterus, and you can see up here what's eventually going to be the foregut. Okay, and what happens as development progresses is that we see differentiation, and you can begin to see here the formation of the liver and the stomach and the pancreas and gallbladder as they bud off the alimentary canal. Notice again that the liver is connected to the gallbladder via the hepatic duct, and the gallbladder is connected to the liver by the cystic duct, and these both form now the bile duct, which is eventually going to enter the duodenum as it fuses with the pancreatic duct. Okay, and these will both produce secretions that are going to aid in digestion in this very critical region of the small intestine. Now, occasionally what can happen is that we can have malformations in the development of the digestive system. Cleft palate and cleft lip is basically a failure of the hard palate to fuse at midline in the formation of the oral and nasal cavities. And the problem with this condition is that the child is going to have a difficult time nursing because formula or breast milk will be forced into the nasal cavity, and then from there can enter the trachea and the lungs. And so this is generally surgically corrected by doctors that specialize in a division of surgery called craniofacial surgery. A tracheoesophageal fistula is basically an opening between the esophagus and the trachea where the two are actually joined. And again, this is incompatible with the ability to feed, so this has to be surgically corrected as well. Fistulas can occur in a lot of different places. You can have fistulas anywhere along the alimentary tract, and they can fuse with any other organ. These are basically opportunistic openings between two organs that shouldn't normally exist, and they have to be closed off. Cystic fibrosis is an inherited disorder of a sodium pump that produces thick mucus which can block a lot of duct systems throughout the body. In the digestive system, it can block the pancreatic duct and as a result occlude pancreatic juice from getting into the duodenum and affecting efficient digestion of protein, polysaccharides, and fat. Fetal nutrition during early development comes through the placenta, but the GI tract is stimulated by the effects of amniotic fluid that is swallowed in utero, even though it has no nutritive value per se. The newborn's rooting reflex helps the infant find the nipple, while the sucking reflex aids it in swallowing. Newborns double in birth weight in 6 months, and the adult diet by and are on an adult diet by age 2 years. As again, the dentition changes, the secretions within the alimentary canal approach adult levels, and we're able now to tolerate solid food and perform effective digestion. Cholecystitis and ulcers are the problems that affect middle age. Cholecystitis is basically another name for gallstones. The problem with these is that they can occlude either the cystic duct or the hepatopancreatic ampulla, and as a result, bile salts and pancreatic juice can be blocked from entering the duodenum. This obviously affects digestion. The way that we treat this is either with gallstone dissolving drugs or lithotripsy, which are sound waves that can be used to smash up these mineral deposits, or surgical resection. Ulcers are basically erosions in the lining of the GI. Gastric ulcers, which were once thought to be solely due to stress, have now been found to be due to infection of the gastric lining by a bacteria known as Helicobacter pylori, which is sort of an interesting pathogen. What it does is it attaches itself to the gastric mucosa and then secretes an enzyme called urease that generates a pH-neutral cloud around where it colonizes the gut so that it doesn't get digested by the gastric secretions in the stomach, and it feeds off the food that comes into the stomach via the esophagus. It's treated with antibiotics. Not everyone is susceptible to colonization by these bacteria, and as a result, not everybody has gastric ulcers. Other places that ulcers can occur include the duodenum. This is often due to the entry of chyme into the duodenum without effective neutralization as a result of interaction with bicarbonate that comes from the pancreas. And you can also have esophageal ulcers that result from acid reflux that can produce not only erosions of the lining, but in any of these areas in the digestive tract, they can perforate, and this results now in the leaking of contents inside the alimentary canal into either the abdominal pelvic cavity or thoracic cavity, depending on which particular organ we're talking about that's affected. Other problems, GI tract activity declines as we age. We produce less digestive juice. Our absorption becomes less efficient. The peristaltic movements slow down, and we have less frequent bowel movements, so this tends to lead to constipation. This is why it's recommended in the diets of those over the age of 50 that we include a lot of fiber. Okay, this can come in the form of fruit juice or fiber caplets, and the idea, again, is to increase the movement of fluid into the fecal material so that it becomes easier to pass. Our taste and our smell become less acute, and as a result, we're less interested in eating in general. This reduces our total food intake and our total energy output. And periodontal disease often develops due to salivary gland secretions that become less and less frequent as well. This also increases the incidence of dental caries. Diverticulosis develops as a result of a lifetime of use of the GI. We can also experience fecal incontinence, and cancer of the GI tract is fairly common. The reason for this is that in any tissue that rapidly divides, you have the potential for a genetic mistake at every area of cell division. And so you tend to see higher rates of cancer in tissue such as epithelial tissue, connective tissue, and other tissues that divide rapidly, such as the blood, the lymph, and so forth. In tissues that divide seldom, if at all, you see very low rates of cancer. And so the lining of the GI represents one of those areas that divides constantly, and as a result is going to be prone to more cancer events, because the apparatus that reproduces our genetic material is not perfect, and as a result there's always the potential for a mistake which could occur in a gene that controls cell division. Stomach and colon cancers rarely have early signs or symptoms. This is one of the reasons why they have such a high mortality rate. Metastasized colon cancers frequently cause secondary liver cancer. Prevention involves regular dental and medical examinations. The earlier these conditions are detected, the more effectively they can be treated. And the reason for this is that if we engage in chemotherapy or radiation therapy while the numbers of cancer cells are low, it's more likely that we'll wipe out all of the offending tissue before it gets a chance to spread throughout the body. If we wait too long, if we wait until it spreads to the lymphatic system and occupies the lymph nodes, then the likelihood of getting all the cancer cells begins to diminish, and the outlook, the prognosis becomes poor. Okay, that brings us to the end of this chapter. I will see everybody in class, and have a nice rest of the day.